Okay. Good evening, everybody, and welcome. It is Fertility Talk Live again. And this evening we are on Facebook. We are talking to Dr. Professor Ingo Siebert. He's from Aevitas Fertility Clinic in Cape Town. So thank you very much, Professor, for joining us and taking your time out to do this talk with us. Endometriosis is quite a big subject. And I've only recently, like the last few months, or I think the last talk I had with one of the doctors at Aevitas, and actually understood how severe how endometriosis can be, endometriosis is and can be, and how it does affect you. So we have a few questions. And again, thank you for joining us. Please tell us more about yourself and where you're from.
Yeah, thank you for that. I'm a small town guy. I grew up in a small little town in Murraysburg in the Karoo. I'm one of the partners and director at Aevitas. I'm a fertility specialist. I'm also an endometriosis surgeon, and I'm an associate professor at the University of Stellenbosch, being involved in the training of the fellows of the young gynecologists studying to be reproductive specialists and helping them also with endoscopic surgery.
Wow, so you got a full day every day. You got quite a lot of things going on.
Yeah, it is a full day, but I love it.
Okay, that's great. So again, we're talking about endometriosis and fertility. If you guys have any questions regarding your fertility or endometriosis, you suffer from endometriosis, and you would like to ask a question to Dr. Siebert, please just put it down in the comment section on Facebook. I will be checking my phone to see if we have any questions through the talk. So Professor, one of the first questions we have is, what is endometriosis?
Yeah. So it's endometriosis for me is an enigma. I think it's a very strange disease, and we don't up to this point really know how to manage endometriosis. So endometriosis is when the lining of the uterus, what we call the endometrium. So just briefly go one step back. In a woman's month, you menstruate. So you shed the lining of the uterus. The name of the lining is the endometrium. Okay. Then you, after the menstruation, you select an egg. The egg produces estrogen. Estrogen builds up the lining, the endometrium. You ovulate. If you conceive, obviously, it's fine. If you don't conceive, you menstruate again and you shed the lining, and the lining's name is the endometrium. Now, if you could remember, all of us had some or have some idea of how the uterus looked like. So a uterus has got two natural orifices. It's got the cervix. So normally the endometrial fluid will run out the cervix into the vagina, but it has got also a tube. And that's where the sperm need to go through to get to the egg. So if you imagine a balloon full of water and you prick two holes, the water will spurt out through both of the holes. So when you menstruate, this endometrial fluid can flush back through the tube and go and grow on the outside of the uterus. It's a natural process, but it's all dependent on your own immune reaction, or whether you are genetically predisposed, whether those cells are going to develop endometriosis, or whether your immune system will be able to clear those cells. So I like to also use the comparison of a grass band. So if you imagine now, I do a hysteroscopy, a camera into the uterus when you menstruate. It will be inflamed, it will be raw inside your uterus. Those cells sit on the outside of the uterus. So my comparison is that of a grass band. If your child or if yourself fell on your knee, the knee is raw, you've got a grass band, you can't put pants on. The pants will get stuck. Yeah. So endometriosis is when those raw cells of the inside of the uterus sits on the outside. It acts like a glue and everything can get stuck to it. And that causes then all the problems which I'm sure you will ask me about. So summarize. Endometriosis, in when the cells of the lining, which is called the endometrium, flows outside the uterus, start to grow outside the uterus, make these raw areas, and then that will cause the damage and the pain and the anatomical distortion.
Wow, it sounds really painful. How is endometriosis diagnosed?
Yeah, so clinically is a major part. So you've got different components. You've got a clinical component, and that is history and your examination. Then it is your ultrasound. It's a special investigation. And then it is surgery or other investigations like an MRI, which normally should not be needed if we do the right clinical history and the ultrasound. So the classical symptoms of a woman with endometriosis is if you have severe pain with menstruation. So think of that grass burn area, pain with menstruation, chronic pain during the month, pain with intercourse, because those cells are growing at the back of your vagina, inside your pelvis. And because of these inflammatory changes and the anatomical distortion, it's the inability to conceive. So clinically, if you listen properly to a patient, you already start to have a high risk profile. On examination, clinically, if you do a vaginal examination, you can actually feel endometriosis if it is present in the vagina. When you do an ultrasound and you have a cyst of endometriosis, that will confirm the diagnosis. Just remember, not all cysts are endometriosis cysts. So you get functional cysts, which will disappear on a monthly basis. That's not an endometriosis cyst. An endometriosis cyst is a pathological cyst that will persist. It will never disappear. And it hasn't got the features of a cancerous cyst. So if you do your clinical examination and you do your ultrasound and you have your background of your history, then already you are pretty much 90% plus sure that you will have endometriosis. The final diagnosis is that of a laparoscopy and then visually seeing the endometriosis, taking biopsies, sending it off for histology, and then confirming the diagnosis. So again, the short of the long is you must listen. There's a specific history on examination and ultrasound, and then eventually on surgery and your biopsies of that tissue.
Wow, okay. How does endometriosis affect your fertility?
So, yeah, it's a pity I can't. I must actually show you a picture. Can I share my screen, or is it going to be difficult?
I'm sure you could. Share advanced. Oh, there we go. I've just given you sharing rights, so you should be able to share it.
Okay, let me just quickly see. I'll just want to quickly. Sorry about that.
No worries. Again, if anyone has any questions for Professor Siebert, you can please put it in the comment section. I am checking the comment section all the time on our Facebook page, and he'll be very happy to help. If it's something that he can't answer immediately, he will leave his details and you can contact him at Aevitas Fertility Clinic, and they are out in Cape Town. So for those of you in Cape Town, he would be available to assist you.
Can you see my picture?
I can see you. There we go. I can see it.
Can you see my play screen?
Yes.
Right. So let me just quickly show you a picture. Okay, so this is a normal uterus, the fallopian tube, and the ovary. Okay,
I think
at
you
the
just
back
need to move it a bit down, Professor, because we're just
pardon?
seeing, I think you just need to move it down to the third slide, because we're only seeing the first slide right now.
Oh no. So what slide are you seeing now?
I'm seeing the first slide, slide number 1.
Ay. Oh no, and this is not working.
Okay.
Do you see the full screen?
I see it's a full screen, yes.
Okay, so let me just go back.
Oh, wow.
Can you see that now?
Yes.
Can you see this?
I can definitely see this.
Okay, so this is the normal anatomy of a uterus, the fallopian tube, and the ovary.
Wow.
At the back is bowel, and at the front is bladder. So what you can see here is everything is free. The tube, the ovary, the bowel, everything is nice and free. So remember I said with endometriosis, those endometrial cells flows out of the tube and it can sit anywhere inside the pelvis and cause this raw area.
Yeah.
Can you see this picture?
What slide are you showing us? That's number 30.
Yes, it's a big ovary and the black on the inside. Can you see it?
That is slide 32. So we're seeing part of 32.
Slides with me, but can you see the ovary?
Yes.
So this is an endometriosis cyst. Okay, so just keep that in mind. Can you see the next slide? We talk about a toxic cyst. Can you see this?
No, we're still seeing the very same slide, sorry.
All right, let me just go back again. All right, so let me just go here. Can you see this slide now?
Yes.
All right, so that's the way that I should do it then. So this is then a woman with endometriosis. There's the uterus, and now you see both ovaries are stuck at the back of the uterus. And you see the tube is not in a position to be able to catch the egg. So there's anatomical distortion due to the endometriosis. Okay, if I show you the next picture, here, this is the grass-burn area of endometriosis. So now you can think, if you have this, there's an inflammatory response inside your pelvis that will negatively impact your fertility. And this inflammatory response also causes then anatomical distortion that your spontaneous conception can't occur. So if you start to understand what is endometriosis and how it can impact your normal anatomy, you clearly understand why you will present with infertility.
Wow. Well, thanks for that, Professor. What are your options when you are diagnosed with endo, and what treatment does Aevitas offer?
Yeah, it depends on it absolutely depends on what your needs are. So I'm going to stop sharing. So it absolutely depends on what your needs are. So is your need pain, then you can either use contraceptive, something like Vazan, a Mirena, to stop your ovulating. So remember I said the endometriosis starts with ovulation in your cycle, the buildup of the endometrium. So you can start with conservative treatment like contraceptive. If that does not work, you need surgery for pain. So if your predominant symptom is pain, then it's either medical hormonal treatment if you don't want to conceive because it's a contraceptive, or it is surgery. If your predominant feature is infertility, You have pain, but you want to conceive. Again, you can't do hormonal treatment here because hormonal treatment is a contraceptive.
Yeah.
So you can't be then on hormonal treatment. Then your only alternative is to do either surgery to improve your natural fertility or to do something like in vitro fertilization, where you bypass the tubes and the ovarian disproportion, like I showed you in that last picture.
Oh, okay, we've actually had a question on that. So Jillian has asked, I've recently been placed on Vazan. It's been 2 months and I'm still bleeding and meds is making me feel sick. Is this normal? I have severe pelvic pain.
All right. So if anybody that puts you on Vazan, I help with the launch of Vazan. It's a brilliant drug. But 15% of women on Vazan can have severe side effects. They can experience severe side effects. And the three major side effects are the following: abnormal bleeding, anxiety and depression, and very tender breasts. Those are the most common side effects. If one of those or all three side effects persists over a period of 3 or 4 months, Vazan is not for you. Then you're part of the 15% that needs a different drug.
Okay, great.
So 2 months perhaps short, wait another month or two, and then you make a call.
Okay, perfect. And then next question is, how can I increase my chances of conceiving with endo?
All right, so as I showed you that one picture where both ovaries were stuck at the back of the uterus, so good proper surgery can then free the ovaries, put the tube and the ovary in the normal position, and then remove those endometriosis cells. So there's a very interesting score. We call it the Endometriosis Fertility Index score, EFI score. After your surgery, your doctor should share the EFI score, your EFI score with you, because the predominant reason, if you present to me with infertility and endometriosis, is to improve your fertility. But it might be that I can't, that your disease is so severe or that your tubes are damaged that we then on that EFI score will tell you, but your chances now only 20% over the next year to be pregnant, or no, your chances 60 to 80% in a year to be pregnant. But that all depends on that EFI score after the surgery. So if your presenting symptom is infertility, you need then after your surgery with your doctor look at your EFI score to ask the question, was the surgery adequate?
Yeah.
How does the pictures look? Can I conceive now? Or should I go and do something like IVF?
Okay, great. This last question is, does endometriosis increase my chance of miscarriage?
Very interesting question. So endometriosis is also or can also be associated with adenomyosis. And adenomyosis is when the endometrial cells infiltrate the muscle of the uterus. If you have adenomyosis, yes, your chances are definitely increased to have miscarriages. If you only have endometriosis, there is also a very small risk that you can have miscarriages. So yes, if you compare yourself with a person without endometriosis, you have a slightly higher risk to miscarry.
Okay, well, thank you very much, Professor. That's all questions we have at the moment. And I always say that as soon as we finish the talk and all the questions do come up, because I think there's a slight delay always from Zoom to Facebook. So if anyone has any questions for Professor regarding endometriosis, oh, yeah, I've got 3 more questions, sorry. Sorry, Professor. I did 3 rounds of IUI and it didn't take, but did first round of IVF in January and I'm 8 weeks pregnant today. What makes IVF work and not IUI?
Okay, that's an excellent question. So if you think of the picture I showed you of the normal pelvis versus the endometriosis pelvis, if you do an IUI, you are depending on natural fertilization. So we inject the sperm into the uterus, but the sperm need to run through the tube and the tube need to catch the air. So if my tube and ovaries are not in the correct position, whether I have intercourse or whether I have an IUI, there's no difference because it's natural fertilization. And then IVF is the answer because you bypass the tubal ovarian interaction. You take the egg out, fertilize outside, and transfer into the uterus.
Okay, and then the next one is not a question, but it's actually a comment and says, from Bianca Fish, says, I just want to say thank you, Professor Siebert, and Aevitas are brilliant. Thanks for everything you've done for me, Professor. So that's a very, very nice comment from Bianca. Thanks, Bianca, for that. So if anyone wants to get hold of Professor, he is at Aevitas Fertility Clinic. I don't know if you want to give some details, Professor.
Yeah, so our telephone number 021-506-4083. My secretary is Glenda, and you can reach her at admin, like administration, admin@aevitas.co.za.
Perfect. Thank you very much, Professor. Aevitas has you can go to the website as well, and you can also, they've got a full page on our website, so fertilitysolutions.co.za. You go to the Western Cape Fertility Clinics, and Aevitas is right there. You can contact them there. They're on Instagram, they're on Facebook. You can contact them there as well. So thank you very much for your time. And if anyone have questions, please do contact us, and we will send it off to Professor. Have a great evening, Professor.
Thank you very much, and thanks for your time, and enjoy the rest of your evening.
Thanks, Professor. Bye.
Bye-bye.